This week on the BackTable podcast.
I do think some of our kids with pretty severe clefts and skull base malformations, they're just always going to need a tube or some type of ventilation drainage place. But if they've got a subtotal perforation and a near maximal conductive hearing loss, so you got to do something. Sometimes I'll graft those drums and I'll probably use tragus for that. But then also I did my ear fellowship with Herb Silverstein, and he put in these subannular tubes that actually go underneath. And if you've got the drum already lifted up to do your tympanoplasty, it's actually a pretty easy thing to slide one under there.
Hello, everyone, and welcome to the BackTable ENT podcast, where we discuss all things ENT. We bring you the best and brightest in our field with the hope that you can take something from our show to your practice. Now, a quick word from our sponsor. Cook Medical's Otolaryngology Head and Neck Surgery clinical specialty strives to provide otolaryngologists with minimally invasive solutions to address unmet needs. Areas of focus include head and neck, otology, and laryngology, with products ranging from a full suite of interventional silendoscopy products and the Doppler blood flow monitoring system to the BioDesign otologic repair graft and the Hercules 100 transnasal esophageal balloon. For more information, visit cookmedical.com/otolaryngology. Now, back to the show. My name is Gopi Shah, and I'm a pediatric ENT. We have an awesome topic today on tympanic membrane perforations in children, and I have two returning guests. Let me introduce them. I have first Dr. Walter Kutz. He's a neurotologist and professor at the University of Texas Southwestern Medical Center. You all may know him. He's been a guest and host on previous BackTable ENT episodes on topics including otologic manifestations of migraine, hearing loss, and cognitive decline, eustachian tube disorders, and congenital hearing loss. We also, returning today, we have Dr. Daniel Choo. He's a neurotologist whose practice is now almost entirely pediatric focused, and he's the chief of pediatric ENT at Cincinnati Children's Hospital. He was also recently a guest on BackTable ENT episode 78, Leadership in Pediatric Otolaryngology with Dr. Dana Thompson and Dr. Shoham Roy. And it is my pleasure to have you both back on the show today to talk about tympanic membrane perforations in children. So welcome back, guys.
Thanks, Gopi.
Thanks, Gopi.
So before we get into it, y'all want to just first tell us a little bit about yourselves and your practice for any of our listeners who might be new to BackTable or who may not know you guys?
Yeah, my name is Walter Kutz, and I've had the pleasure of being on BackTable before. Always enjoyed the episodes and especially listening to the other episodes. I'm a otologist, neurotologist at UT Southwestern. I finished my fellowship in 2007 at the House Ear Clinic and joined UT Southwestern. I've been there ever since. I would say about 70% of my practice is adult, 30% is children. So I usually operate about 3 to 4 days a month. And then I have 2 clinics, and I see a lot of pediatric patients through my UT Southwestern clinic as well.
And what about you, Dan?
So it's striking that I've been in Cincinnati now for 24 years. And I'll confess that during my residency in Syracuse, the hardest and most onerous part of our rotations were the peds rotations. And so I came out of residency thinking, I'm going to have a height line on my office door, and if you don't come up to that line, you can't come in my ride. So to be practicing in Cincinnati Children's is really strange for me. My background is, like Walter's, also in otology, neurotology, training in Florida as well as in Washington, D.C. at NIH before I came out here. But it's a great, very gratifying practice to work on kids. I do probably about a third of my work is implant-related stuff, hearing loss. Another third is congenital ears, and then another third is revision chronic ear stuff like we're talking about today.
Obviously, I love children as well. My practice is all pediatric ENT, but I do not have the height marker at the door because I need to make sure that I pass that marker. For those of you who do not know me, I clear 5 foot, and that's about it. So, all right, so let's get into it. So the reason I wanted to have this podcast topic on tympanic membrane perforations in children is because, one, I think that sometimes diagnosing them can be difficult to make that decision making about how to manage, when to watch, when to consider surgery, and then the surgery itself and post-op can be difficult. So let's just first talk about how some of these kids present to you. How old are they usually? What are some of the symptoms? And kind of go from there.
They seem to come in different phases. I'll get my 3, 4, 5-year-old kids who've had one or multiple sets of tubes in their earlier lives, and then as the tubes fell out, they're left with a residual perforation. mixed in there, but overlapping in that Venn diagram. Then you got these kids who just develop these chronic suppurative ears that just drain, and they always have a perforation and seem to manage those with and without tubes. And you end up at this place where they've got holes in their eardrums. And then a smaller proportion are those kids who come back later, either from a traumatic or maybe they had just had a fluke acute otitis episode that perforated, and they come in with these clean, dry, very sclerotic looking perforations. Each of those you manage obviously just a little bit differently.
Yeah, it's pretty similar in my practice. Sometimes, a child may not have any really symptoms and they get their first hearing screening in school. They just have a little hearing loss. You come to see them, they have a dry perforation, which I think a lot of times is probably from a tympanostomy tube that extruded and they have a persistent perforation.
I usually will ask any history of drainage, how's their speech, how are they doing in school? What are the things on the history? Are y'all asking, or do you always have on your checklist of questions?
I like to ask about, have they had a history of tympanostomy tubes? I think it's very important. A lot of these kids, if they don't have a cholesteatoma, they don't really have drainage, they have a mild hearing loss, we're going to follow them for a while. And so if they're really struggling in school, perhaps that may be more incentive to repair the perforation or at least consider a hearing aid. I think asking about cleft palate, does a child have other craniofacial abnormalities, allergy problems, these sort of things are really important. Also, I think asking about the contralateral ear is important. Are they continuing to get infections in their contralateral ear? I'd be less likely to offer a tympanoplasty in that situation.
And then the physical exam, sometimes I find it can be kind of difficult. Sometimes there can be a history of the perf and documented it on my last visit. And sometimes, maybe it's the 4-year-old or the 6-year-old that just doesn't want me in their ear that day. Are you always using just standard otoscopy? Do you use a microscope every time? How do you get the exam and how do you follow it? Do you ever put a scope in, flex or rigid?
I'd love using an endoscope in the ear, but in the clinic, it's a little bit onerous for us, and I'm not sure what your guys' experiences are, but it's a little bit of work to hook it up, and it's so much easier to just walk them down to our room where we have the microscope. It's pretty rare that we've got to get into a formal wrestling match with a nurse or a MA, mom and dad, and as well as myself to get a good look. If the parents are comfortable, I'll also try and work into it. Maybe it won't be 100% exam on this visit today, but you'll come back in a month or so and we'll take another look and I'll gradually ease the kids into it. The standard otoscopes, I think we can probably get by with that, a majority of the time, and the kids will let you get a decent look and you'll get a good enough idea as to the scope of the perforation. But boy, just like we've seen in the operating room, the endoscopes give you so much better view. It's pretty sensitive though, to put that in a squirmy 4-year-old kid. That would be tough.
Yeah, I'm the same way. I enjoy using endoscopes in the operating room and use them frequently like Dan. But in the clinic, it's challenging. If you bump that X-ray canal with an endoscope, it really hurts. Even with adults, you have to be much more gentle and thoughtful than if you're using, a speculum or a microscope. And I think, like you said, if you kind of talk to the child and you try to gently look in the ear, you don't necessarily have to remove all this room in the first time. If you can get an idea what's going on, just like Dan said, I think you just sort of get to know the child, know that, hey, I'm not going to hurt you. And then you can even come back and take a look later.
Yeah. If I have a chronic perf that I'll watch, I might, and the child is older, maybe like 6 to, depending on the 6-year-old, maybe 8. It kind of depends. Once a year, I might try to put a camera in just so that the family can see it. We can all kind of see it. And then when I see them back in 3 to 6 months, depending on their symptoms, I'll use just a regular otoscopy. Or if I still can't get a great look with otoscopy, if it's super interior, I just need to get a better view, then I'll use the microscope. And then I agree, putting a scope in the ear. So I know a couple of times I'm like, let me try the flexible. It's softer and I can still get a good look. But it's so long and big that even trying to, oh my God, you're going to stick this big old thing in my ear. And they sometimes aren't having it either. And I agree, sometimes, with an endoscope, it is very nice, but the heat on the light has got to be turned down because even that, just having the heat can be painful or scary and just make them kind of jerk. And so a ding there is not necessarily what we want. But I think the families, if they can see it, like it too. And if we can see it better, it's kind of nice.
I think that's been great. When we renovated our clinics several years ago, we put video monitors on each side of the wall in the microscope room so that whatever ear you're looking at, the kid can also see, which I found has been very, very helpful. They'll let me do a ton more if they can see what I'm doing to them. And then when it comes to discussing surgery, it's been so much easier to talk off the screen with the family.
Well, you had mentioned some of the risk factors, underlying eustachian tube dysfunction from craniofacial, like cleft palate. We do have a special group of whether it's syndromic, non-syndromic, cleft palate, or children with trisomy 21, have eustachian tube dysfunction that can end up with residual perfs or get a perf that doesn't heal and so forth. How do you think about those kids? How does that underlying risk factor kind of play a role into your decision-making of how to manage?
Yeah, I think I'm more likely to follow those perforations, especially if they're not causing really any issues. They're a small perforation, they're dry, there's no cholesteatoma, hearing's still good. It's basically acting like a tympanostomy tube, which a lot of these kids are going to need anyway. Now, saying that, my overall big 3 criteria to fix a perforation would be if there is evidence of a cholesteatoma, if they have chronic otorrhea that is just, they're on multiple sets of ototopical drops, and maybe sometimes they get a lot of oral antibiotics from their pediatrician. And then if they have really significant hearing loss, those are the kids I will typically address. But kid with cleft palate, other syndromic issues, high risk of eustachian dysfunction, oftentimes I'll try to follow them as long as I can. And a lot of times, even if some hearing loss, they can wear a hearing aid pretty successfully.
I'm on the same page. There's different points in my career where I felt like, oh, I can close that one. That'll be all right. And you get burned a few times. I said, all right, I need to dial that back a little bit. It's rare that I've been disappointed that I waited longer. There's extremely rare instances where a very benign looking perf ends up developing some squame growing into the middle ear. And I said, I should have gone back in before that developed. But that's a pretty rare exception, I think. I'm more sensitized. And I don't know if it's from living in the Ohio River Valley, but the environmental allergy stuff, rhinosinusitis with associated eustachian tube dysfunction, is a real bugaboo for me. There's kids where we patched them up successfully, but then they come back with recurrent fluid and you end up poking a hole back through with a tube and a drum that you just repaired. And you feel like, oh, why did I do that? So we're more cautious about those for sure these days.
Do you try to get them evaluated for allergy, put them on medication? Like, how do you sort of manage that part of it or consult?
If I'm suspicious about that, certainly starting on history and physical, we'll try and probe it and see if there's a family history of environmental allergies, which I think is a risk factor. Take a quick look in their nose, see if their turbs are really swollen, chronically congested. I'll usually start putting them on an antihistamine and some Flonase type stuff. But if they still have symptoms after that, then that's when I'll usually refer them on for formal allergy testing. The frustrating one is where it comes back all negative, and you and the family are saying, I know my kid has allergies. I wish it's shown positive, and we figure out what to treat in more targeted fashion.
Those are definitely harder. Those are usually the slightly older kids, otherwise healthy, and it's hard to know sort of, like you said, which way do you go with that underlying eustachian tube dysfunction. Well, you'd mentioned the contralateral ear. What about an otherwise child with no other medical comorbidities, but they have bilateral perfs? How do you determine the contralateral ear?
Yeah, that's a great question. And, look at the literature, and some people have kind of cutoffs, 5 years old, 7 years old, 8 years old. Again, if I've been in this situation and some, in Texas, it's really hot in the summer, kids want to swim, they get their ear wet and it's miserable for them. And so I probably do maybe a few tympanoplasties at a little younger age than, maybe that I'd prefer, and usually get away with it. I don't really have a strict age cutoff. I think every kid's different. Some people may have a guideline of 7 or 8 years old if it's just a dry perforation not causing trouble. But if they don't have the risk factors and have a careful conversation with the parents, usually I try to maybe get them a little older, out of that eustachian dysfunction stage. I don't know if that's 6, 7, 8 years old, something like that. Oftentimes I think the parents appreciate that you're not just wanting to operate right away. You're building a relationship. Once you do the surgery, hopefully it's successful, but it's not successful. You've had this conversation a few times, and I think you've been thoughtful about your decision-making. So again, I don't really have a strict age cutoff, but even a 5 or 6 year old, even with bilateral dry perforations, the parents understand that there's a chance the child made another tube that may not heal properly, very low risk of retraction of cholesteatoma, then, I think proceeding carefully is reasonable.
Yeah, I would say the interesting part about the relationship with our patients and our families, a lot of times when I've been waiting on these kids for a while, it's actually the parents who say, hey, is it about time? Can we talk about fixing this thing yet? And I'll say, oh yeah, that's right. We were going to do that now about this age. It's much more comfortable. I think that shared decision-making at that point inspires a lot more confidence for them.
Absolutely. And like you said, if the hearing's good, the speech is good, we're not getting drainage and it's dry, what's our goal here? And so kind of having to split that up functionally, how are they doing? And what's our audio show? And are we having problems from it? a tympanoplasty surgery, the post-op care isn't sometimes like if you have to suction or if they have drainage, like it's not an easy recovery, or that sort of dry ear. If you're going to do drops, if you have to take a look and suction anything out, there's more to it than sometimes just, okay, we're going to go ahead and start tympanoplasty, because the why I think is important. Every once in a while, I've seen kids maybe between the ages of 5 to 7, and we've been watching a dry perf, and the hearing test is still good, but the size looks bigger. Do you watch that? What do you do if you notice, is this getting bigger?
That's not that common of a problem, but I've seen that. I think I would do the same criteria. If their hearing is still reasonable, if they're 5 or 6 and the parents want to wait another year or two, that's fine. You do worry about things like secondary acquired cholesteatoma. They can sometimes be difficult on exam. And so, things like persistent or recurrent otorrhea, that may be higher incidence of secondary acquired cholesteatoma or just chronic suppurative otitis media. This is not going to get better without surgery. But I think I'd follow the same sort of decision-making. I wouldn't be as concerned about a larger perforation, although typically that's going to cause more hearing loss. You'd probably be more tempted to repair it anyway. But I think I'd kind of follow along as I would regardless.
Yeah, same for me, Gopi. I don't know. Does it change your thinking or your approach?
Well, if the hearing is good, I don't feel like a rush, but I just worry. I'm like, is it just going to make the repair harder, or the chances of closure harder if that hole is bigger? If we're starting with 40% and now it's like 70, and every once in a while the audio looks pretty good. The kid's doing well in kindergarten and language is good, and it's always hard to know. And so maybe I'll see them, as opposed to usually for my stable kids, I'd see them about every 6 months to get an audio and an ear check. But maybe I'd see them a little bit sooner at 3 to 6 months and really talk to the family about, see how they're doing in school. If they're getting in trouble more, if the teacher's calling you, it could be that we have a change in the hearing, or, when they're swimming, we may want to be a little bit more particular about plugs and things like that.
Yeah, I think on the size of perforation, I still like doing lateral graft tympanoplasty, and I feel kids heal really well from this. And so even a subtotal perforation, in some ways, that operation is very standardized for me. At Gopi, we work together. It's the same kind of operation every time. It looks the same at the end. I actually enjoy that operation. So I guess in my hands, the size of perforation may not matter as much. Saying that, if it's one I'm going to do a medial graft and use an endoscope, and it's more that anterior superior, those are more challenging, I think, heal less commonly, but it's something to consider for sure.
I think the size, that probably hits on it well, is the location of the perforation, and what you got to repair is probably the more significant driver of, should you fix that before it gets worse up in that anterior superior corner or not? But you're such a house guy. Who does lateral grafts these days?
They work.
In terms of the location, the anterior perfs or like the anterior superior, do you follow those, more carefully? What's your decision making on those for a child that's between that 3 to 5 years old? The tube fell out and they ended up with like a 25% anterior superior perf.
I don't think it changes too much. I'm still following. Does it get infected a lot? Does it drain? And is there hearing loss? And those are the things that the parents seem to bring the kids in and get worried about. So even if it's a pretty decent sized anterior superior perforation in a 3-year-old kid, we'd probably say, you know what, let's watch it for a little while longer. We'll stack the deck. And when we actually do repair this, we'll be at a point where it's probably going to be one and done.
Yeah, I agree with that. I think just talking about a little technique, it's nice having partners from different training. Jake Hunter was with our group for about 6 years, and he did a lot of over-under type technique where he'll deglove the malleus completely. And I think it gives you really good access to those superior anterior perforations. So that's something that I'd been cautious about in the past, because I always thought the drum may lateralize off the manubrium. But in reality, if you don't overpack the middle ear space, it's a very good technique. And I'll use an endoscopic approach typically. So, I'm not just the house guy. I am also willing to learn different techniques that seem to work very well. But, I think over time, you kind of learn what works for you. And I think it's okay to change and try some different techniques.
Maybe that's a good segue, Gopi, for technique pieces to this, because for those, I always felt it was so, maybe not invasive is not the right word, but to deglove the malleus and do all that work to get up to that front corner. I've been doing a lot more cartilage grafting for those. And, if it's small enough, even trying something like a butterfly graft for that, to me, that felt almost wrong because it was too easy and I didn't struggle enough to get a good result. But I'm struck by how often you do get a great result. And the hearing is good, and it's a really quick healing, quick recovery. And as opposed to degloving the malleus and going that way, a lot of times I'll skew my tympanomeatal flap a little bit more inferiorly and anteriorly and lift the drum up from bottom up, and that lets you get around the malleus and get the graft up where it needs to be. Packing and supporting the graft up in that top front corner is still really hard, though. I think that's one of the failure-prone areas for us still.
Yeah, I agree. That's very similar. I would typically do a medial graft and leave the skin on the malleus, and trying to pack that superior anterior is very difficult. And one instrument that's been helpful with that is the Thomason dissector. You can it's that right angled with the little spatula tip. Dan, you know about this. We use it a lot in the endoscopic world, but it works great for microscopic world as well. But you can sort of turn and place your gel foam kind of around that malleus, and it helps. But it doesn't seem like you can ever quite get a packing up that superior anterior space. It's challenging. I do agree. If you can do something like a fat graft, or I do a lot of butterfly grafts, but something just simple. You've tried something that's going to probably have a really high likelihood of working. You're not going to really disturb the rest of the anatomy of the tympanic membrane. I think that's definitely worthwhile and a really good point.
Is there a certain size criteria for a butterfly cartilage graft? A size that's too big that you were like, no, I think I'm going to have to just do a standard tympanoplasty? And for our listeners who may not know, this is the cartilage graft where you're kind of making it into like a grommet, correct? And you're kind of taking some of the epithelium off of the tympanic membrane and making sure so that skin isn't trapped in it, and then kind of popping it in like a tube.
There's a lot of variables. The location of it definitely makes a difference. In some ways, having a little meringosclerosis around the perforation in those actually can be a little bit helpful because it gives your graft something to really butt up against and holds it steady. In very rough terms, I'd say if it's more than 3 millimeters in size, I'm probably going to do something more formal, lift up the drum and try and graft it.
What about fat? Do either of you guys do the little fat plug?
I do that. I probably should do that more often. I figure if you're going to sleep, I'm an otologist. I think a lot of otologists are like, well, I'm going to do a formal tympanoplasty. I'm going to have that nice 80 to 90% success rate. Fat grafts, probably less than that. I don't know if it's that much less, but I do think there's been times where, I've looked at a perforation. I'm like, probably could have just done a fat graft, give that a good try. And I would probably say that's sort of same. If it's greater than 3 millimeters, I'd consider, formal tympanoplasty. Dan, I don't know, how do you do fat grafts some here and there? Or?
That's pretty rare. I think what's supplanted it more for me lately is I've been using a good bit of the porcine submucosal intestinal grafts. I think it's commercially available, pretty benign, easy to work with stuff. And if there was something where I was going to do either a fat graft or even, I don't know, some people do a gel foam plug and a perforation after roughing it up. With some of these synthetic grafts, you can just clean up the edges of the perforation, pack some gel foam underneath it to support the graft, and then just work right through the hole. It looks a whole lot prettier, and it feels like it's a little bit more intentional than just stuffing some soft tissue into the hole. And that's my baggage. I will tell you, if I don't struggle enough, then I'm probably not going to get a good enough result.
Yeah, that I guess you can call it kind of like a stuffer, where you take your fascia or whatever, you kind of stuff it through the perforation. And that's something else I've thought of. I probably should do that more often. Yeah, I guess one warning for the audience on that, if the patient has significant conductive loss, one of the disadvantages of that's actually would be considered a meringoplasty because you're not entering the middle of your space. If they do have a significant conductive hearing loss, you're worried about the ossicles or cholesteatoma, that'd be maybe one argument to do a tympanoplasty. But most of the time, they don't really have a lot of conductive loss. And I think doing something that's pretty straightforward and simple would work well. I've had some healing issues with the porcine submucosa grafts. Have you had any trouble with larger perforations, maybe 50, 70% perforations, or they seem to be healing okay for you?
No, I don't like using that on the larger perforations like that. I don't know if it gets a vascular supply fast enough, and then it's a race. The more distal portions are going to start dissolving away and left with a recurrent perforation again. But I have been happy if you've got a subtotal perforation. Let's say you decide to use some tragus and some perichondrium, and there's still a little gap there. Using the submucosal stuff to kind of fill in whatever defects you have there, it seems to epithelialize pretty quickly from that.
Yeah, Dan, you mentioned use of cartilage. I've actually, interestingly, probably used less cartilage over time, even in kids. And it seems like my results they seem good. I haven't looked at them systematically. You really don't know your results. You'll be humbled if you look at them systematically. You're just like, oh, it heals every time. They're like, oh, well, no, it only healed us 70% of the time. But, I think one of the challenges, maybe one of the points you brought up is when you use cartilage, cartilage is pretty rigid and the drum's actually very kind of a dynamic, almost like a cone shaped. And so I think sometimes I put cartilage in there and I think just that, the cartilage doesn't really sit under the drum and you have that little gap. And I've seen some of these heal up. We have this little crescent shaped residual perforation. And it sounded like you may take some of the porcine submucosa or a little perichondrium and kind of fill in that little gap. Is that right? Is that kind of what you were describing?
Yeah, exactly.
That's a really helpful tip.
I'm curious. So I'm going in the opposite direction. I'm probably using more cartilage than I did 10 years ago. I'm really happy with the healing outcomes. It has made a little bit of a difference in a positive way. And so far, I think I'm still seeing good hearing results from it. And especially on those anterior superior perforations that we talked about. I think that area really helps me. What's made you shift the other way, Walt?
I think it's just I think the fascia or the perichondrium is just pretty no nonsense. It's simple. You place it in there. It's going to really form underneath the drum. You put some packing. And I think some of the cartilage, I think it's a little hard to size. If you're going to do like a shield piece of cartilage, you're going to cut out that strip of the malleus. Sometimes it's difficult to make sure that's not contacting the malleus or the right angle. But like you said, in reality, all the literature and our experience shows that cartilage doesn't seem to really negatively affect the hearing results, which is really surprising. But there's been literature upon literature that really shows there's really not much of a difference. I think the fascia of the perichondrium is just simple to work with. And now a kid with cleft palate, recurrent perforations, those sort of things, I'm going to use cartilage. Just buy yourself more time and have a better chance of healing result. But these kids that maybe it's just a tube that came out, it didn't heal well, they had a traumatic perforation, the USH tube go on the other side. I just usually use fascia and perichondrium. I think the more people lean to using more cartilage over time, but I've just kind of used a little less recently and it's seemed to be working okay.
What kind of tricks do you have to shaping the cartilage graft? Because cartilage, I agree, is difficult to kind of maneuver to get exactly where you want, sizing it and estimating it. I don't think I appreciated it until actually working with you, Walter, and Brandon when I was a fellow and being like, hey, this is the important stuff's actually, hate to say it on the back table, where the, where you're actually harvesting. That's where the attending is harvesting the graft. Like, how do I know what size and what angle and what shape? So any tricks on that?
Well, I was going to let Dan answer because he's the cartilage guru here. But no, I've used a lot of cartilage. Gopi, and I think when we were working together, I probably use cartilage in most cases. What I like to do, I've done it a lot of different ways. I think John Dornhofer, if you want to read some literature, I think he has really good techniques and well explained if the listeners want to look at some more literature regarding cartilage graft and tympanostomy. But I've done shield grafts. But what I like to do now is I'll place usually perichondrium or fascia if it's a large perforation. I'll actually place the cartilage separately. So I don't really do these composite grafts as much anymore. So I'll fix the perforation or have the perforation covered with a soft tissue, and then I'll put cartilage underneath that. And of course, you want to support that cartilage with gel foam. If I'm going to use cartilage, that's typically how I'm using it.
I think we've been, and this is in a period where probably 85, maybe even 90% of my eardrum perforations were fixing endoscopically. And so I'm hesitant to make a separate incision behind the ear to harvest fascia. And so I'm using a lot more. That may be one of the drivers, Walt, why I'm doing more cartilage, tell you the truth. And our trainees definitely do struggle with making the graft the right size and shape. When it comes to harvesting, we always take as big a tragal graft as you can. And I tell people it is physically impossible for you to harvest too big a graft. We leave the tip of the tragus, so hopefully it doesn't deform too much. And then more recently, I've had the trainees take the foil pack from one of our sutures and just kind of create a template, start working with it, and it gives them a much more concrete shape and size that they're going to trim the graft to. And especially with an endoscope, I started out asking them, take a round knife and measure it out when you're looking in there. Tell me how many round knife diameters are we going anterior to posterior, superior to inferior. But one of the pitfalls there is that with the endoscope, they get a bit of this parallax, and it can make the round knife look bigger or smaller in relation to the perforation. And then when we actually cut it and put it in, you're like, holy cow, how did we end up so off on this thing? So that's where the foil pack has come in more. I've been much happier with that. It's rare that we put a cartilage graft in there and it's like way out of sync with what the hole is like.
Yeah, those are all good tips. And I noticed what's something just kind of fun about otology is that, I think your techniques change a little bit over time, probably your whole career. it's very creative in a lot of ways. There's different ways of doing it. And, I'll go see somebody give a talk and, even this conversation, I'll, let me try that and, try that a few times. I agree with all those. And it's, as you become really more experienced, you can sort of just eyeball it and cut it pretty accurately every time. But that takes many, many cases to do that. So I really like the idea of templates. If you use like an 8mm speculum, that's a pretty good idea of, how large the drum's going to be. So you could even just stamp that with a marking pen or something just as a start. And then, that's another way to sort of size things.
My first few years out, I would separate it because I liked that technique. I always found the composite, maneuvering it, managing it, measuring it, fitting it how I wanted a lot more difficult. So I liked separating it. And I think the way you would kind of remove some of the excess cartilage off of when you were doing a composite, there was a few times when you did, off of the fascia, you use the small round knife just so that you wouldn't pop through the fascia, just gently. I liked those two things that you used to do too. Tell me about, we had mentioned some laryngosclerosis. When you're doing formal tympanoplasty, when is it helpful and when do you decide to take that all out? How do you know what you're going to leave in and what you're going to take out?
I got a pretty pragmatic but not consistent approach to it. I really dislike grafting, say doing an underlay graft to a bunch of laryngosclerosis. I just can't see that healing really well. So I'll start peeling away at least till we have a couple of millimeters, if not a few millimeters of healthy drum that we can contact with fascia or perichondrium. And sometimes as you're doing that, the whole thing just peels out like a plaque, right? And you look really slick and say, oh, this is great. Other times it's so adherent that you just start tearing away more drum. So very pragmatic when it comes to that. I hate to take something that would have had a good healthy margin of native drum and then booger it all up by trying to peel away the plaque. But at least a couple millimeters, if not a few millimeters of drum epithelium that we can graft to makes me feel a lot more comfortable.
Yeah, I think my approach is very similar. And I think laryngosclerosis there's different sort of severity. That really thin, little discolorations, a little whitish, that's probably fine. If it's thick where you take a 5910 beaver blade or a rose and you can't at all poke through the thing, you're afraid you're going to injure the testicular chain or something, that's probably not going to heal well. And, even for small medium perforation, one thing I do like about a lateral graft technique, and it could be with, if you do underlays, I feel comfortable removing the drum. If it is really thick, diseased drum with this really aggressive laryngosclerosis, I'll just remove all that and then put a fresh piece of fascia in there, and it's typically going to heal pretty well. But it's always a question. People ask me that. I think it really depends. You want to have a very systematic way of doing it, but all the laryngoscopes are a little different. It's a different location of the perforation. Like Dan said, sometimes you can peel it from the undersurface of the drum, sometimes you can't. So a lot of times it's a game day decision.
Tell me about otorrhea game day. So let's say, two scenarios. One is it's patients in pre-op and they got snot coming out of their ear. And let's say the second scenario is you don't really see anything in pre-op, but you go to the OR and there's drainage and there's some granulation tissue. How do you guys manage that? And also, thirdly, do you routinely look in with an otoscope before surgery, before the patient goes to the OR?
I was just trying to think the last time I canceled a case in pre-op because we were going to fix an eardrum and then the kid had some otorrhea at the time, and I really can't remember. So for better or worse, we kind of plow ahead. I am one of those believers where I think some of our chronic recurrent otorrhea kids have biofilm disease, and cleaning them out at the time of tympanoplasty is probably a good idea. If anything, rather than doing something minimalistic like a butterfly graft, if the kid's draining and the ear looks fairly hot, we'll turn a tympanomeatal flap, clean everything out as good as we can. Up until recently, I was also a big fan of putting in some otiprio into the middle ear space when we do that. And that's that long-acting quinolone. It's in a hydrogel. You squirt it in at a liquid, and then when it hits a 37-degree environment, it kind of gelatinizes. And then it stays in there for about 3 to 4 weeks. So in the early healing period, you're giving the ear a fighting chance to stay clear of an acute infection. Give that graft a chance to take. Unfortunately, they're going to stop marketing that in the U.S. because they didn't have a great demand for it.
Does that have steroid in it too?
No, so no steroid component in that one.
Yeah, I have a similar approach. I can't think of the last time I canceled a case because of otorrhea. Now, I was intraoperative. I wish I would have canceled the case. It's a total disaster. But, I think one really good hint for, newer surgeons, and I just, been in practice a long time, just you keep learning things as you go. But, if a child has any history of otorrhea, just tell them to start drops 1 week before surgery. I usually tell them to start Ciprodex or some drop with a fluoroquinolone and a steroid. And I think that can really help prevent some of this. Sometimes I'll forget to tell them or they'll forget to start it, but I'll proceed. And there was a good study at a house years ago when they looked at patients that had a dry perforation or a draining perforation at the time of surgery, and the healing results were really about the same. It just makes surgery more challenging. The other thing too is sometimes you get such bad meningitis that it's hard to know where do you stop rimming the perforation, and so it does make it more challenging. But we typically push forward, and I think Dan's got a good point. A lot of these kids just have biofilms, and they're going to drain. They're going to cancel them, and they come back 3 months later, and they're draining again, right?
Any tips on, because when the ear is inflamed, it's going to bleed a little bit more. Any tips on hemostasis?
Well, I think with the endoscope, I've learned to use 1 to 1,000 epinephrine a lot more often. I didn't really use that much, and I use it with the microscope now too. But if you take, you can do gel foam with 1 to 1,000 epinephrine, or you can use little 1/4-inch patties. It'll stop bleeding very quickly within less than a minute. And if you get a lot of bleeding, just put some down there, wait a little bit, and then take that out. You can proceed.
Yeah, I agree. I think it's just patience, which is really hard for us, right? Because you got to stop a little bit more frequently, let it dry up, dissect a little bit more. It's really hard when I'm not the primary surgeon, just watching that.
Right.
Okay, so any other tips or tricks about surgery itself? Because I was going to then kind of lead into some of the post-op care.
I'm kind of curious what you guys think. Walt, you do a ton of endoscopic stuff as well. We're shifting to our fellows will probably have done more endoscopic ear surgery than they have microscope. And part of me is being old fuddy-duddy otology, neurotology feels like, man, you got to learn your microscope skills. That's a very different skill set. So these days, I actually give the fellows and the residents their preference. Like, all right, how do you want to do this one? Microscope, endoscope. Most of them are actually gravitating towards an endoscope. They really like that. What are you guys noticing?
That's the same experience. Our probably past 3 to 4 fellows, they probably have a little more endoscopic experience. Typically, a lot of these I'll start endoscopically, and then I try to tell them, hey, we need to make a decision early, right? If they have a secondary acquired cholesteatoma, they've got a lot of granulation tissue, you got a lot of bleeding. Sometimes it's just quicker and better for the patient just to go post-auricular, use a microscope. You're not defeated if you convert over to a microscope, right? It's just a tool. We're still ear surgeons. We're doing ear surgery. It doesn't matter if you're in a microscope or endoscope. No one ever has to use an endoscope and have great results. I like to be able to use both. And especially the residents, they really like the endoscopes. They get a lot of sinus surgery. And so they really like to use endoscopes. And a lot of our fellows, I'll say, well, how are you going to do stapes? How are you going to do tympanoplasties? Most of them are using endoscopes for those operations. So I do agree you're worried about losing some microscopic skills. If a case is going to take 50% longer to use an endoscope, it doesn't make a lot of sense to me for a small post-auricular incision. One thing I'll mention about just an operative point is every time you do a tympanoplasty, make sure to look under the remnant tympanic membrane. I think one of the most common cause of failure is actually even behind some cholesteatoma, like a secondary acquired cholesteatoma. A very common place would be under the manubrium. So always look there. I had a case recently, had a residual perforation. I knew they had a secondary acquired cholesteatoma. I thought I removed it all, and I bet I left a little bit behind, and it's just not going to heal well. And then obviously left a cholesteatoma behind. So I think it's a good pearl to always lift that remnant drum, make sure you don't see that shiny appearance of epithelium, because this probably happens more commonly than we think, especially in these patients with these draining ears.
Do you use a 30 for that, or does it matter?
I think a lot of times you use a 0 degree, but I guess if it's a small perforation, you don't have a nice tympanoidal flap, you could use a 30 to help out.
Tim Gopi, I got a question for you.
Yeah.
One of my frustrating things after a pretty straightforward tympanoplasty is every once in a while you get this kid who still has a mild conductive hearing loss. Drum looks great. Middle ear space looks nicely aerated. And I just can't get their air bone gap closed. And I've scanned a bunch of those kids saying, where did I leave something, or where are their adhesions? And the scan looks really benign. What do you guys think is going on there?
I wonder if there's maybe some sort of scarring between the ossicles, maybe just because of manipulation. There probably are some adhesions that we just don't see in a scan that can be thin and strandy. And maybe the way that eardrum heals doesn't vibrate as well, too. I mean, those are the things. And I've had those kids. And it's just like, God. And then usually I'll be like, oh, dang, I'm going to have to send them to Dr. Walter Kutz now for another opinion to see, do we need to do anything or can we watch it? Like, what are we going to do? But it's super frustrating. And then I've had the other kids where, darn, there's a little hole still left, but the hearing is good. But that's a good result, right? Anyways, to the question that you asked, it's probably just from manipulation scarring, whether it's the ossicles, because, we check the ossicles and you're still, tucking a graft underneath and, you're still doing stuff. It's going to move a little bit could be some straining of adhesions that we don't see. And just even the way the drum vibrates now, it, may not be vibrating the same way. I don't know. What do you think, Walter?
Yeah, I mean, there's probably a lot of reasons. And, we recently published some tympanoplasty results, and I was like, man, our mean inner bone gap was like 10 or 12. I was like, what? What is going on? But if you look at the literature, that's about where your mean air bone gaps, even just simple medial graft tympanoplasties. And we always think, well, we should get total air bone gap closure, but that doesn't always happen. And I was really surprised when I think there's something going on with the technique, but I looked at the literature, there's still going to be an air bone gap in most kids, and it's bothersome. Now, when he gets 15, 20, then you're really like, you're worried about, what is really going on. And I think it could be many, many different things. It could have, some tympanosclerosis that's causing some vesicular chain, not immobility, but maybe some impaired movement. You're right. It's amazing we get the results we do with replacing a tympanic membrane, using all this cartilage, all these sort of things. So it's probably multifactorial. And sometimes the parents really focus on that, right? You can see on the graph, wait a second, the hearing in the operated ear is worse than the good ear. I'm like, well, the operated ear is not a normal, natural ear, right? We have to repair it. And so, if it's a 10 decibel air bone gap, it's not going to probably affect the child. And that's in reality a good result. But otology is humbling, that's for sure.
So in terms of post-op, do you drops a couple weeks later? For how long? If the kid doesn't do drops, does that change your management? And do you have to suck the packing out week 3?
I usually have them start drops, 10, 14 days after surgery. One trick, if the drops bother the kid, parent can put it in their pocket for 10, 15 minutes. I think warming it up a little bit can help. It's pretty rare that I think drops actually burn, but we do have patients that describe that sometimes. Yeah. And in reality, for the young kids, I just put them on drops for a long time because I do like suctioning out the packing, but there comes a point where it is just not good for anybody to keep going after the packing. And, a lot of times there'll be a little packing anteriorly that you just can't remove on anybody. And I just continue drops for a couple more weeks. It usually takes care of it.
Yeah, I think that sounds pretty familiar. I'll see my kids back somewhere around 3 weeks post-op from a typical tympanoplasty, and then won't start drops until I see them, and then cleaning out the gel foam, whatever is convenient and comes really easily, enough so I can get a peek of at least part of the drum to see how it's healing up. And then they come back probably another month after that. And that's when we'll do a more formal clean out if there's anything residual, as well as a early hearing test to see where they're heading.
When do you usually get another audiogram after surgery?
So it's typically at the second post-op visit, I'll get one. And I'll give the parents the caveat. I said, listen, I just want to know where they're heading and see if we're in a good place early on, but it'll still get better for another few more months. So that's typically 3 weeks from the first visit and then 4 weeks after that one. So around 7-8 weeks, pretty typical.
I do kind of a 3 week, and then I'll check the hearing in 3 months after surgery. Now, if there's some concern with healing, I'll see him again at 4 weeks after that initial 3 week visit. But a lot of times, if the thing looks like it's going well, I'll see him at 3 weeks. I've already started him on drops, and then I'll just see him back at 3 months with an audiogram.
How long do y'all do dry ear precautions for?
About 4 to 6 weeks.
4 weeks. How about sports and weightlifting and all those kind of things?
I was so conservative. I'd be like 2 months. I don't know. I was so conservative with water and heavy lifting and sports. I'm like, these are not our skull-based patients. This is okay. This is healing. But I would just be super conservative about it.
Oh man, and your patients don't revolt on you?
They probably do. They just don't tell me.
Well, especially that if they had a vesiculoplasty, right? Then I did have one patient that, obviously football's big in Texas, and played, I think it was actually 2 or 3 months after surgery and they dislodged prosthesis, but you're not going to tell them not to play football for 2 or 3 months. That's one of those unfortunate occurrences.
For any of our craniofacial kids, any nuances or double checks belt and suspender type things that you do for the perforation that you're repairing in the child with Down syndrome or the cleft palate history that, you're doing it, they have the hearing loss or it's otorrhea.
I do think some of our kids with pretty severe clefts and skull base malformations, they're just always going to need a tube or some type of ventilation drainage place. But if they've got a subtotal perforation and a near maximal conductive hearing loss, so you got to do something. Sometimes I'll graft those drums and I'll probably use tragus for that. But then also I did my ear fellowship with Herb Silverstein, and he put in these subannular tubes that actually go underneath. And if you've got the drum already lifted up to do your tympanoplasty, it's actually a pretty easy thing to slide one under there. You drill almost like a little trough where you're going to recess the tube just a little bit under the annulus area and then lay the drum down on top of that. So you give them much more of an intact drum, hopefully improve their hearing, but still leave them with a tube. Never been happy putting a tube through a grafted area of the drum. That just seems to come back with these huge holes for me. So this was one way to kind of get around that.
I've thought about doing subannular tubes. That makes a lot of sense. What I'll do on some of these really tough ears that you need a chronic tube is I'll just punch a hole through the cartilage, use like a 5 suction, sort of push that down through the cartilage and take a small, like a 5910 beaver blade and make that hole. And then I'll put a T-tube through that. And those patients tend to do really well. I've had a number of patients who have had that tube in for years. I think one of the tubes is going to stay in. They can get blocked, but it'd be simple enough. I think you go to the OR, pull it out, and put a new one back in. I don't recall one being blocked, but that's certainly going to happen one of these days. But you're right. You're grafting a drum and you're sort of putting a hole in the drum with a tube. But these are, somebody you just know has porous tube dysfunction.
Do those tubes eventually fall out on their own, or do they stay in forever?
Well, I haven't been in practice forever, but they most of them seem to stay in. How about the subannular tubes? Same thing. They'll stay in, Dan, but they get blocked and things. That's what I've heard.
Yeah, you do have to do a little bit of maintenance to keep them open, but I haven't had one fall out. If we've ever wanted to, we had to pull it out.
And then quickly, in terms of hearing rehab options for the child that we didn't repair or the child that had the same or worse hearing outcome after surgery, audiology visit, hearing aid, preferential seating, tell me, FM systems.
I think all those, you definitely want to document things and talk to the parents about preferential seating. Let's say they have a unilateral mild, moderate hearing loss. If they're, kids in Texas Medicaid, they're not going to be able to get a hearing aid. And it may not be worth that much money just to buy a hearing aid, but, an FM system can really solve those issues in school at least and help learning. One thing, if you don't fix a perforation, most kids can tolerate a hearing aid, but there's a chance with the moisture retention that they're going to get chronic otorrhea. But, I leave that to the parents. If they have bilateral, moderate, severe hearing loss, those kids really probably should encourage to wear hearing aids. Also can't forget the bone anchored hearing devices, the new transcutaneous devices. We've had really good success. I've converted a number of patients from the percutaneous to the new transcutaneous, and they really like the sound quality better, probably gives a little better high frequency hearing. And now they don't have this post sticking out of their scalp. They just put on a magnet and use it with their phone and everything else. So that's another option that can be considered. But you don't want to forget about the hearing component, obviously. And if a kid has, or a patient has bilateral cholesteatoma, terrible hearing, a lot of times the first surgery, I'll just put in a percutaneous bone anchored hearing aid because they may have hearing problems for 2 or 3 years by the time you operate in one ear, do a second look. If you do second looks, do the other second look, and you may not get a good hearing result. So I think putting a bone anchored hearing aid as soon as you can will at least give them, you're going to solve the hearing issue until you get this all fixed. So that's something to think about.
Yeah, I agree, Walt. And the percutaneous ones are so reversible, right? It's such a benign intervention that you try to talk them into. It's a hard sell sometimes to tell people you can have this little post sticking out through your skin, though. Have to get them acclimated to that.
For my adult patient kids, if they don't like it, they don't need it anymore, just unscrew it in 5 seconds. And I will mention one thing. If you're going to do the transcutaneous, you got to think about it. You need to do a diffusion weight MRI in the future. So typically, if somebody has chronic otitis media, unless I just know that ear is safe and very unlikely to have a residual cholesteatoma, I'll just do a percutaneous. That's something to think about because you get even though it may be MRI compatible, you're going to get so much scatter with that Baja device that it's not going to allow you to do diffusion weighted MRI to look for residual cholesteatoma.
So as we wrap up, do you guys have any final pearls or maybe something that you do differently now than you did 10 years ago?
So I think 10 years ago, I wasn't doing a ton of endoscopic ear surgery. And I think that is I hate to say game changer, but I do think there's some real impact that it's had, probably more so in cholesteatoma disease, just the enhanced visualization. I think we're getting better at eradicating disease that way. And then in line with that, with us doing more transcanal endoscopic approaches, I definitely am shifting towards a little bit more cartilage than I did 10 years ago. And just circling back to one of the points we talked about, sometimes you get those really thick cartilages and you hate to put that much mass underneath your eardrum or in your eardrum. And the cartilage trimmer is something I'm using more. It's to really shave it down and make it a thin piece of cartilage. I think still conveys the structural support that you want without imparting such a big mass on the eardrum.
Yeah, I agree with that. I started using endoscopes in 2014. And like I said, it gives you another, way to deal with ear disease. And, if somebody's cholesteatomas in the sinus tympani, you just can't see with a microscope. And if you're a skilled endoscopic surgeon, you can put a 30-degree scope, you know what to look for, you know how to prevent all the fogging, you know about hemostasis, you know the right instrument. And there's been a number of times even where it may be a microscopic approach, I'll pull out an endoscope. And I think before, and I was more of did a lot more endoscopic surgery, it would have been a real challenge. But now if you use the endoscope frequently, it's not a big deal and it can really enhance surgery. So I do agree. That is something that has certainly changed in my practice. I think, as you might have mentioned, Dan, I think as you get more and more experience, you get more humble. And there's definitely, early in my career, I'm like, oh, we can fix that. This is going to be great. And now I think it's more a lot of, let's watch this perforation. You sort of know where you may get burned because you've been there before. And that's just part of your experience as a surgeon. And everybody has to go through a little bit of that. But I think that's something that, I rarely regretted being a little more conservative initially.
Yeah, absolutely. I think for the endoscope, Dan, you had asked this or mentioned this earlier with the fellows, especially on the PD side. I mean, that's what we're used to, right? Endoscopes in the sinuses, endoscopes in the airway. So an endoscope in the ear is something probably, if you're doing PD, you're probably going to gravitate to more. And then in terms of, being conservative with a perf in a kid, I've never been burned being conservative with a perf in a kid. But anyways, thank you guys so much. I learned a ton. If our listeners have any questions or want to learn more about you guys, are either of you on any social media?
No. Well, I do add Twitter, so EarDoc1, and then Instagram, which I don't do as much as Walter Kutz, MD.
Awesome.
Walt, you're so hip and fresh. For an old guy, it's shocking.
I don't have TikTok. My kids want me to get TikTok. No TikTok here.
All right. Well, Dan, if anybody wants to get a hold of you, reach out to us at BackTable ENT. We'll try to pass the message along. For our listeners for stopping by, thank you for joining us. If you have any comments, ideas, or ever want to come on the show, please reach out to us. That's a wrap. Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend. If you have any questions or comments, direct message us at _BackTable ENT on Instagram, LinkedIn, or Twitter. BackTable ENT is hosted by Gopi Shah
and Ashley Agan.
Our audio team is led by Kieran Gannon, with support from
Josh McWhirter,
Aaron Bowles, Nick Shellcross,
and Ness Smith-Savadoff.
Design and digital marketing led by Brian Schmitz, with support from
Taylor Spurgeon-Hess and Ivan Orgodzinsky.
Social media and PR by Chi Ding.
Administrative support provided by Jamila Kennebrew.
Thanks again for listening and see you next week.